Hello, everyone. I'm going to tell you in a while, but I can give you a small idea. We have 47 different locations, okay? Coming from Algeria, Austria, Bolivia, Brazil, Bulgaria, Chile, Colombia, Costa Rica, Ecuador, Egypt, El Salvador, Estonia, France, Germany, Greece, Guatemala, India, Indonesia, Iraq, Ireland, Israel, Italy, Japan, Jordan, Korea, Malta, Mexico, New Zealand, Nicaragua, Norway, Panama, Paraguay, Peru, Portugal, Qatar, Dominican Republic, Russia, Serbia, Slovenia, South Africa, Spain, Saint Vincent, Turkey, UK, Uruguay, USA, and Venezuela. These are the 47 regions joining the meeting, so which is really, really, really global meeting, okay? We are on time, so we're going to start. Have people already texting? Well, welcome everyone to this unique female incontinence meeting that we have called Meet the Experts, primum non nocere secundum curare. As I was saying, we have around 950 participants of this meeting, which is incredible, a record for a urogynecology meeting, and we are so glad to receive you here with these key notable speakers. It is a great honor for me to be here presenting Professor Peter Petros, Professor Paulo Palma, and PhD Dr. Emmanuel Delorme. Their names already say a lot in the urogynecology field. In fact, we were thinking on calling this meeting as Meet the Legends because we consider them as being notable, renowned speakers. And by saying their names, we all know what we're talking about. All of them, in a way, have pushed the borders, have researched for the new frontier in patients' care, improving the efficiency and trying to bring safer devices and concepts. This is why for me it's again a great honor in the name of Promedon to present Professor Peter Petros. He is the Honorary Professor of Medicine at the University of New South Wales, Sydney, Australia, and he's the creator of the integral theory and one of the creators of the TBT concepts. Second, Professor Paulo Palma, Honorary Professor of Urology at the University of Campinas, Sao Paulo, Brazil, and he's been the creator of the mini sling concept and Ophira in the case of Promedon. And third, PhD Dr. Emmanuel Delorme, urologist at the Hospital Sainte Mary Lyon, France. All of us know him by being the creator of the TOT procedure technique, quite globally used these days. So, being an honor, as I said, and before entering the official presentation, a small dynamic comment. You will find at the bottom of the screen some Q&A button from where we're going to get all the questions. And at the end of the presentation, we're going to try to find 3 or 4 of them and ask the presenters their opinion and their discussion. So for me, welcome and thank you, all of you, for joining this meeting. Professor Palma.
Good day, I mean, because we have different times around the world. Thank you, Alejandro. It's a pleasure and an honor for me to be here. The introduction and overview I'd like to share with all of you today is mainly about concepts. And that's a really important issue for allow us for understanding what we are doing. So I'd like to start with a question. How urinary incontinence was managed in the past? So let's get back to 1908, as Dr. Fraga liked to say. At that time, the Olympic Games in London, 1908, there was no differential diagnosis between stress urinary incontinence or urge incontinence or mixed incontinence. All these situations were managed in the very same way. In the same year, 1908, in Paris, Giordano presented for the first time his sling technique, a muscle upon an aortic flap from the abdomen to the vagina to close the bladder neck. Well, this technique had lots of complications, was abandoned, and have some modifications. What's the rationale and theories or hypotheses regarding incontinence? We have the abdominal pressure transmission in Harness, 1961. Peter Petros in the integral theory that talks about mainly damaged ligaments. The hammock concepts, the Lancey, the facial lesion from 1994, and Bergstrom created the urethral hanging hypothesis. So let's talk about that. The inhorning is a passive concept for pressure transmission. So it believes that when the intra-abdominal urethra received the same amount of pressure, there was continence. On the other hand, when this kind of transmission was not good enough, leakage occurs. It's a pressure equalization concept. The intra-abdominal urethra associated with a nice or vaginal flaccidity. It's a passive concept that do not take into account any anatomic detail. So, taking the bladder neck as a sphincter, hypermobility and the shortening of intra-abdominal urethra, the management is the bladder neck suspension to a high heteropubic position that is not anatomical, leading to anatomical distortion, bladder outlet obstruction, voiding dysfunction, and recurrence. The integral theory takes into account mainly the support elements of the urethra. His urethra, the pubo-urethral ligaments, the uretropelvic ligaments, and also the vaginal wall. Here is the pubo-urethral ligament. This patient is leaking, and this is the simulated operation. When we do the simulation of the pubo-urethral plication, the patient becomes dry. And the same is true for the uretropelvic ligament. We do a simulated operation, the patient coughs, and does not leak anymore. When we remove the clamp, she starts leaking again. So also the integral theory take into account the opening of bladder neck and the proximal urethra, put these links not more in the bladder neck, but in the mid-urethra, and allowing for the retropubic approach, the TOT, green and yellow, and from only yellow, from arc to another arc. This is the mini sling. The hammock is this. Support the urethra. It's not really a theory. In the normal patient, the urethra floats over this hammock. And when there is a damage of the hammock, as you can see here, the urethra tends to sink. This is from Mozambique. Igor Vaz had this patient. You can see here a tear of the hammock. The patient is leaking when you do some pressure, and you correct the hammock, she stops leaking. the urethral hanging theory that should be more hypothesis is very similar to the integral theory. It takes into account the tear of the posterior pubourethral ligament, and 1 centimeter from the bladder neck is the VP, vaginal point. And this scientist advocates that we should put at the vaginal point these links because it's natural and you are allowed to treat even patients with no urethral hypermobility. So I take the words of Alejandro. It's a pleasure to me to be here with two friends, but two legends, Peter Petros, when visit us, and here Emmanuel Delorme and myself when we were in Sicily, in Palermo, with Gigia Gilli, performing surgeries together. So we are talking about quality of life, and incontinence impairs quality of life. And when we can restore the continence with no complications, we transform the wet world in a wonderful world. Thank you.
Thank you, Professor Palma. Now we're going to go with Peter.
Okay, good evening, and good evening from Sydney, and good morning to some of you. My lecture is Understanding the Mechanics of Stress, of Closure and Stress Urinary Incontinence are the key to better surgical technique. So my lecture is a general lecture on anatomy, and now a little bit of history, how it all started. I had read Robert Zacharin's work. Robert Zacharin did some beautiful anatomical work and described the pubourethral ligament, but he didn't know what its role was. Around about 1986, I formed a hypothesis that the problem was collagen defect in the pubourethral ligaments. If you look here, you'll see the pubourethral ligament inserts into the urethra and the vagina, and that if you haven't got any collagen, collagen is a structural component of the body. If there's no collagen or defect of collagen in the ligament, if you put pressure on it, it'll come down. And you can see here what happens. I thought, well, okay, if that's how it works, if I put a hemostat here, it should stop the urine. So there it is. And she's coughing. You can see it coughing, no urine leak. And all I was doing was putting a hemostat there and stopping it coming down. Now, this is a transperineal ultrasound, and at rest, you can see the bladder, the urethra, the symphysis. You can see the anterior vaginal wall, the posterior vaginal wall. Okay, and there's the posterior bladder wall and the urethra. Now, what happens when somebody strains or coughs? I showed you that if the ligament is loose, then it can't hold things up. There's the symphysis. Right here is the pubourethral ligament. You can actually see it. And when the patient strained, you could see that it's called funneling. The bladder neck opened up and the urine came out and the distal urethra was open as well. Look what happens to the anterior posterior vaginal wall. They're pulled downwards. You see that? Look at them. They're pulled down. Okay. Now, I showed you what happened with the, when I put the, I think with, Ivan, you're blocking my screen. Could I put you off a bit? Hold on. Here. Can anybody see this? There should be an arrow here. Can anybody see a white arrow? It's being blocked by all these people.
No, we are seeing nicely.
Yes, we can see it.
You can see the white arrow.
Yes.
What the white arrow does is it exactly as the same as a hemostat. It restores, it stops the pubourethral ligament lengthening, and it restores the distal and proximal closure mechanisms. You can see the bladder neck is closed. That's a yellow circle, and it's also closed distally. All right. Now here's a video again, and you'll see the three directional forces. That was the first major discovery of integral theory. If you want to understand integral theory, you've got to understand there are three directional forces: forwards, backwards, downwards. Now, again, here is the symphysis. There's a pubourethral ligament here. You can actually see it here. And here's the bladder neck. Here is the levator plate. There's the anus. Now, the first thing you're going to see...
ultrasound demonstrates the three opposite directional forces which act to close the distal urethra and the bladder neck. The first force is activated by pubococcygeus muscle, pulling the suburethral vagina forwards to close the distal urethra. The second force is backwards. It is the levator plate stretching the bladder base back in preparation for the downward rotation which closes bladder neck. This is activated by the downward acting conjoint longitudinal muscle of the anus.
And watch this. The levator plate goes down.
The anterior part of levator plate.
Down.
To
Look.
rotate and close bladder neck.
All right. So now this is very important because I hope you will start reading integral theory system, because those three muscle forces explain everything. Tethered vagina, urge incontinence, everything. So understand that the first really important discovery was the three opposite muscle forces acting against the pubourethral ligament anteriorly and the uterosacral posteriorly. Now, some anatomy. It's not quite as simple as the pubourethral ligament. So we've got the symphysis here, pubourethral going into the mid-urethra and the vagina. Now there's a pubovesical ligament here that was described by Engelmann Sundberg, and it inserts into the anterior wall of the bladder in the arc of Gilvernay. It's a thickening. And when the first thing that happens is the forward muscle stiffens all this, right? Forward, then the backward stretches it, and then the rotation, this downward force, rotates it around the actually bladder neck. So the closures of bladder neck, and it rotated around the arc of Gilvernay. So the difference between the TOT and retropubic is that the TOT goes horizontally here, and the tape for the retropubic actually follows the pubourethral ligament, perforates the pubovesicle. Okay, but both of them restore the rotating and closure mechanism. Now, again, I showed you what happens is if the ligament's loose, then when these muscles, when the patient coughs or strains, these muscles pull down, and it goes from closed to open, right? From closed to open. That's the extra distance. Now, what I'm going to show you next is very, very important. Up here, it's a urine flow chart, okay? Pressure flow chart. There's a detrusive pressure here and the urethral diameter here. Now, I'm going to talk to you about Poiseuille's law. Poiseuille's law states that the flow through a tube depends on the diameter of the tube. In other words, if the diameter is smaller, then the resistance is exponential, inversely by the fourth power of the radius. Now, if you look here on the right, now, let's say, for instance, you are tightening a sling, right? And the diameter is 4 millimeters. Just an extra half, at this diameter, you need about 100 centimeters of water to push to get a flow rate of 50 mils per second. Now, just an extra half millimeter virtually doubles the force needed to drive the urine through this urethra. Now, think about it. When you're tightening, and you think an extra half millimeter is nothing. An extra half millimeter is a lot. So the point I'm trying to make here is when I want you to think of this graph when you're tightening that sling, because every little half millimeter can cause obstruction or relative obstruction and increase the force of contraction needed to push through. Okay, so let's move on. Now, The second major discovery in 1990 was, we thought, well, okay, we proved that it was loose pubourethral ligament. How do you make new collagen? Well, I worked with Professor Papadimitriou, who was the professor of pathology at the time, and we did 13 experimental animals. We implanted the tape, and the idea was to use the positive reaction to an implanted material in a positive way to create new collagen. Now, all of you know if you get a splinter in your hand, it goes hard, you get collagen. So the idea was we put the tape in and it creates new collagen. This is 13 weeks after implantation. That's a very substantial neoligament. So there's the vagina, the bladder. The original idea was to take the tape out, and we did, but we found that there was within 3 months, 50% of the incontinence had recurred. By then I'd started working with Ormston in 1990. We did 6 experimental operations, and we realized we needed an implanted tape because you take it out, it doesn't work. Okay, so I talked to you earlier about, and this is a retropubic sling, you all know about that. But let's come back to this pressure flow chart. Now, this is a 50 mils per second. And as I said before, if you put you need to tighten the ligament sufficiently so the closure muscles can close the urethra. Let's go here again. It's about 100 centimetres of detrusive pressure for a 4 millimetre wide diameter urethra. If you make that a little bit too tight, 0.5 millimetre, you double the amount of force. Now, so in my experience, most doctors over-tighten the sling, certainly at the beginning, and they were even transecting it. And Emmanuel reported all the a wonderful compilation of complications because people were doing it the wrong way. The sling is not to tighten the urethra. The sling is to strengthen the pubourethral ligament so that the muscles can close. So that the muscles can close the urethra in 2 places, distally and proximately. Now, Paulo talked about the hammock. That's very important. I'll be dealing with that right now. Now, here we are. There are 2 closure mechanisms. There's the bladder neck, which rotates around here, and there's the distal closure mechanism. And it's got 3 components. Here it's got the posterior pubourethral ligament. Here it's got the external ligament, and here is the hammock. And you see the wiggly arrow shows that the force of contraction of closure of the distal mechanism is weak. And here again, now Paulo showed a very nice video, but here's mine. This goes back to about, oh my goodness, I did this in about 1989, a long time ago. But you can see here, if the patient's coughing and just tightening a little bit, just a little bit, it's still leaking, and I'll put the mid-urethral pressure in. So what I'm going to show you now is a technique. Now, this technique which I'm showing you, I recommend that you do it with every single mid-urethral sling that you do. It doesn't matter if it's retropubic, TOT, or mini sling. You need to repair the distal closure mechanism. Now, I'm coming back to this again. How do you know that the patient has got a deficiency? Well, firstly, you can see it, it's loose. But secondly, a lot of the patients will come to you and say, look, doctor, after you do a mid-urethral sling, about 5% will come back to you and say, look, it's terrific. I can play sport. I don't leak when I cough. But sometimes when I walk, I get a wet pants. It just leaks out. and it's like a bubble escaping, like a bubble of air escaping from my urethra, and that's the urine leaking out. Because what does the distal mechanism do? The distal mechanism actually seals the urethra. It's the bladder neck that does the main closure, because it's a kinking mechanism. It's like a hose. You kink the hose. And all right, so how do we fix it? Now, the external mechanism, external urethral ligament, or Robert Zakarin called it the anterior pubourethral ligament. It's the same thing. So first thing you do, you take the incision to within 0.5 centimetre of the urethra. That's important so you can access the external ligament. The external ligament is directly next to, this is next to the urethra. So you put a 2O vicryl, a suture through there, a suture through the fascial layer of the vagina on the left side, again on the right, and again here. Now you always do this with a catheter inside the urethra. Remember, the catheter is your friend. When you're doing mid-urethral slings, the catheter is your friend. So you leave the catheter there and just tie it fairly loosely, not too tight. And here it is again. This is what we suture, this is what we do, and I'll show you a video of this. Now, this is from a TFS mini sling, which is retropubic, and you will see here I'm
preventing it. We'll show you that in a minute.
Tightening the sling.
But the tape has to sit exactly against. Now, putting the suture into the external ligament on one side, into the fascia of the vagina, the suburethral vagina. And the fascia on the other side. And again, into the external ligament on the contralateral side. Now this brings together the loose external ligament and the loose fascia, and it really brings them together onto the tape. So the tape glues everything together, so we get a 3-point restoration. We replace the pubourethral ligament and tighten the external ligament and the suburethral vagina.
Now you'll notice I took the incision up within 0.5 centimetre of the meatus. You saw that? You've got to do that, otherwise you can't access it. Now, I'm nearly finished. So what are the surgical steps for the best results and minimal postoperative retention? The catheter is your friend. You have an 18-gauge catheter in the urethra for every step. I really recommend you use a non-stretch tape because, you know, when you pull up an elastic tape, anything elastic has to restore. And post-operatively, within the first couple of hours, that elasticity can actually come up and close the urethra. It can narrow it. Now, you don't solve the problem by doing it on a bare urethra and then sticking in an 8 Hagar, because the Hagar dilates the anterior urethral wall. These constrictions is underneath. So have the catheter in there while you're tightening, or you can use a Hagar if you want. It's the same thing. With a non-stretch tape, you touch the urethra, but you do not indent it. You do a cystoscopy. This is before you do the suture for the external closure mechanism. You do a cystoscopy. You have a look, and then when you take the cystoscope out, you wait 3 or 5 seconds, because don't forget, you've stretched the urethra. It's got to come back down again, and then you can tap on the abdominal wall. But usually, if it's too loose, you don't have to tap on the wall, it just runs out. So when that happens, put in a Hager. An 8 Hager is very good because you can take it in and out quickly, or we put a catheter back in, and then tighten. Remember the graph of urethral resistance, millimeter by millimeter. Don't go making a big tight, tiny bit, and then take it out and check. Take it out and check. The urine loss will stop. You can press again on the abdomen, or if you do it under spinal, get them to cough. And it's good to see a little bit of urine loss at the end. And the final slide is, what do you do if your patient can't pass urine for 2 or 3 days? Well, don't do what some stupid guys do and wait 6 months and with a catheter in and out all the time. Because by 6 months, the scar tissue's formed. And the scar tissue, I mean, it is a problem removing a tape when it's too tight, because it's actually constricting the urethra. And it's easy to perforate the urethra when you're trying to do it surgically. My advice is wait 48, if they haven't passed any urine at all for 48 hours, or at least 72 hours, you know you're in trouble. Remember the graph. Don't forget that graph that I've shown you. I'll take you back to it. It's so important. At the end of this lecture, we're nearly finished. Wait 48 hours. Now, in 48 and 72 hours, the scar tissue hasn't formed. It's very easy to just loosen it. Stitch it up, send it home. It's work. Now, let me take you back to that graph, because it really is the most important part of this lecture. Here we are again. Now, again, this is the detrusor pressure. Here is the urethral diameter. Now, it does 2 things. Firstly, it explains stress incontinence, because if the muscles can't close and the urethra is pulled open, at 6 millimeters diameter, you only need 20 centimeters of water, a very small cough, to leak. But in the converse, when you're tightening the sling, say at about 4 millimeters diameter, it'll leak. You need 100 millimeters to leak. An extra half millimeter, you need 180. In other words, when you're tightening every half millimeter, the point of this graph is, I don't want you to take this literally, the point of the graph is that the urethral resistance is exponential. That if it's too loose, it'll lose urine at a low pressure. If it's too tight, they can't pass urine. Thank you very much. I'll leave it at that.
Thank you very much, Peter. And now we're going to go with Emmanuel.
Hello, everybody. Good morning, good evening, or good night. It's possible now. Many thanks to Promedon to invite me for this conference. It's great to be with Peter, Petros, and Paulo Palma. I will present you how to decrease TOT complications. My philosophy about the TOT is to do retropubic TOT. Retropubic TOT is a specific technique I developed since 2003 to decrease the complications, functional and anatomic complications of TOT. If we look at publications and the bibliography, we see the subjective curate of TOT is approximately the same with 9-10 years follow-up for in all the good publications. But if we look at the complications, it's very different. And if we compare the first publication on this table with Serati and the complications in the Cochrane, the complications are very different, and we are very interested by pain complications because it is the more difficult complications we can have after TOT. And groin pain are terrible. It's why I work a lot to decrease groin pain after TOT. And if there are if there's a lot of difference between the publication, probably it is because the technique is not the same in all the publication. When we do retropublic tape, it's easier to do always the same technique. It's very safe. But when we do TOT, there are a lot of technique, and any technique are dangerous. And if we look at this publication of Blaine, very interesting. It is a retrospective study of a lot of department of urogynecology, and we can see 10-year follow-up of 60,000 patients. There is 4% complications, and the skill of the surgeon is a base point to decrease the complications, because in the code department, we see that decrease 40% of the complications. It's why I think it's very important to work on the technique. Indications, sure, follow-up, sure, but the technique must be perfect. And it seems me horizontal TOT is one of the techniques to decrease visceral and functional complications. Look on this pelvic bone with the bladder in green, we can see the urethra, and the retropubic TOT described by Petros. It is the reference, and we must have the same support of the distal urethra between the last third and the middle third of the urethra. It is the aim of TOT surgery. And at the beginning, my first publication was very bad, because you can see here, it was an oblique TOT, and the needle was too much on the middle of the obturator fossa, too big mistake that increase the risk of complication, functional and visceral complications. It's why definitively this oblique TOT must be forbidden. But when we do TOT with an helical needle, it's more difficult to do an horizontal TOT, because the good way is not oblique, but horizontal. And with right needle is easier. And we can see here the horizontal TOT or retropubic TOT with the finger inside the pelvis, lateral to the urethra, respects the perineal membrane, and there is a very short way between the needle and the finger, and it is the right way to have the tape exactly on the same place than described Petros for the retropubic tape. We can see here a retropubic TOT on the bone and an oblique TOT, and this oblique TOT is at the level of the bladder neck, bad level for tape, and the retropubic TOT is always in the good place. And the landmark of the TOT is not the skin, but the bone. We will see after different step to have the good landmark and the good retropubic TOT. Here, it is the oblique TOT, bad technique, and the horizontal TOT, better technique to decrease the complications. We come back to the anatomy. The background of anatomy is the main instructions to understand the surgery and to understand the TOT. That is the internal area of the obturator fossa. Here's the pubic bone, here's the obturator nerve, and now we will turn the model, okay, and it is the outside area of the obturator fossa, the pubic bone here. Here it is the two terminal branch of the obturator nerve. The anterior branch, it is motor branch, and the posterior and internal branch, and this one is very important to know when we do TOT. And here it is the age of the pubic and the ischiopubic bone, with a tape here and a needle here from inside to outside. And what we can see firstly, we must be, when we do out in TOT, to be in contact against the bone, to be far away the this posterior branch. There are 15 millimeters between the edge of the bone and this branch. It's very important to be in contact with the bone when we introduce the needle inside the pelvis, is to protect. And when we do in-out TOT, we increase the risk to have growing pain after surgery. That is the situations of to introduce the needle. It is the anatomic view and the surgical view, and we can see here on the anatomic view, the good point is in the corner between the pubic bone and the ischiopubic bone, okay? And in surgical, position of the patient's surgical view, we can see this point here and not there. Okay, there are 3 steps to introduce the needle. First step, the needle go on the bone and feel very well the bone and not inside the obturator fossa. Second step, the needle go outside, and when the needle leaves the bone, immediately stops the way and turn inside to remain against the bone behind the pubic bone. That's the great security to have no injury, no visceral injury during TOT. These movies show well the different steps on the bone. Firstly, the finger look for the narrow the narrow bone between the pubic bone and the ischiopubic bone. The needle follow the bone, and when the needle leaves the bone, immediately the finger inside go up behind the pubic bone, protect the urethra, and the needle go inside, and there is less 1 centimeter to drain the tip of the finger, and you can see the finger guide the needle inside the incisions. And there is a lot of small anatomic steps during this way. And we can see on this anatomic view, it's sagittal sections of the cadaver with the pubic bone here, the urethra, the bladder, and the finger lateral to the urethra, and we can see here the finger push the bladder neck and the urethra and protect it, and the way between the finger and the obturator is very short at the end of this way. It's not a lateral way, it's a retropubic way. And after the obturator fossa, the needle passes through the perineal membrane. And that is very important because that is a meatus, it is an Etherbook picture, and we can see the perineal membrane. If the needle crosses the perineal membrane very posteriorly or very the tape will not be the good place. The needle must cross the perineal membrane just lateral to the meatus, in between the corner, in the corner between the pubic bone and the urethra. That is very important to have the tape in a good place lateral to the urethra. The perineal membrane acts as a pulley to orient the tape in a good situations behind the urethra. That is a summary of the different steps of this surgery. The way of the needle is horizontal, focus on or upper the urethral meatus. The needle gets a contact with the ischiopubic bone and go behind the pubic bone to meet the finger introduced inside the incisions behind the pubic bone. The finger protects the urethra and guides the needle towards the vaginal incision through the perineal membrane in the corner between the last third of the urethra and the ischiopubic bone. And we can see on these anatomic dissections, it's a sagittal section with the pubic bone, the levator muscle, the perineal membrane, the perineal level of the obturator fossa, and the visceral level of the obturator fossa, the bladder, is here. And you can see the horizontal way makes the needle exactly between the levator and perineal membrane in a good space, and the oblique way makes the needle upper the levator muscle. It's dangerous for the bladder. And on this endoscopic dissections, we can see the oblique way and the horizontal or retropubic way. And on this vaginal dissection, we can see the horizontal way and the oblique way. The retropubic TOT route is an horizontal way. Never we must do the oblique TOT, because the oblique TOT increases the risk to have vaginal erosion lateral inside the lateral sulcus of the urethra. Because when we do retropubic, the way of the tape is very high, lateral to the meatus, and not cross the sulcus of the urethra. Second, if we do oblique TOT, the tape will be at the level of the bladder neck, and that is not a good place, as Peter Petros described. For the tape, we will have functional complications. And at the end, if we do oblique TOT, we increase the risk to have a tape inside the bladder. I think when we do TOT with retropubic, the risk to have tape inside the bladder is very low. But between very low and absolutely zero complication, we can do fibroscopy. And when I teach TOT to my residents, I ask them to do cystoscopy. It's so easy to do cystoscopy. And at the end, I will present you my publications about transobturator route. And on these three publications, it's 2,364 TOT route with 0 surgical obturator nerve injury and just 1 growing pain. But this growing pain was not because it was not injury of the internal branch of the obturator nerve, but it was because after surgery, the patient did an abscess and then come back for immediately for the follow-up. It will be very good to remove immediately the tape. And in conclusion, for me, retropubic TOT gave less vaginal erosions, less voiding dysfunctions, no bladder erosions, and decrease the risk of pain. The last point to have the tape in good place, as Peter described, because it's difficult to adjust the tape. In my experience, I use always hypoelastic, non-stretch tape, but every tape is one adjustment and can be different between the elasticity and the grasping of the tape. It's why I think the best link is the tape we have experience. And if we change tape every time, we increase the risk to have bad adjustment after surgery. Thank you for your attention.
Thank you so much, Emmanuel. Thank you so much for your presentation. I just want to do a small reminder for those who have some questions. Please go to the bottom where you will find the Q&A bubble, and there you can write your answers. I will try to answer them at the end. Now with Paulo showing us the future trends or his visions for the future, and then we do the final round, closing the meeting.
Thank you, Alejandro. Well, that's a very interesting issue. What is ahead for 2030? Well, let's start with the first warning of FDA in October 2008. There was more than 1,000 reports on the diverse effects with mesh and slings. And at that time, the first recommendation of FDA was training for pelvic surgeons. There was an impact, as you can see here, in 2010 and 11, 100% of the slings were synthetics. And then, after the warnings, the injectables came back in scene, and in green here, the autologous pubovaginal sling is coming back. But it was last year, April 16, that FDA prohibited the selling, all industries to sell vaginal mesh. But synthetic sling was not included. That's a very important issue. Only in a few countries, the synthetic sling is suspended. But even though we have some impact in the sling as well, this really come back to the past. So the bladder neck theory was revisited. You can see here the Bursch, Marshall Marchetti, needle suspension, and even anterior repairs. But prima nocere, the driving force behind the sling evolution is the reduction of complications rate, as Emmanuel pointed out very nicely. If you go to the Cochrane and compare the evidence-based outcome data from TVT versus TOT in a very high number of patients, you can see that the success rate is about the same. There is no difference between them. But when it comes to obstruction, TVT, you have almost 20% of obstruction and only less than half, 8% obstruction rate on this TOT. According to the integral theory, we have to reinforce this, the loosened sling, the pubo-urethral sling or the uretropelvic ligament. So here we see again, here in red, the retropubic, green and yellow, the TOT, and from one arc, tending to the another arc, the yellow, the main sling. As you can see, Zachary studies this pubo-urethral sling has an anterior portion and a posterior retropubic portion. This is the symphysis pubis, this is the posterior part, and this is the anterior pubo-urethral ligament, and here is the urethra. When we have a collagen defect, the pubo-urethral defect elongates, and that makes that the bladder neck goes moving away from the pubis, changing the angle. The angle is not the problem, have nothing to do with the continence. What we are seeing here is reflecting that this pubo-urethral ligament is loose. Another very important point, the villain. The villain is not the needle. The villain is the length of the blind step. That's why the retropubic TVT was adopted in our center, because the blind steps is only 1.5 centimeters. That means safety. This is the bladder. The bladder is displaced because there is a huge hematoma. Here is the sling, the retropubic sling. And this is a complication due to the blind step of the procedure. This is another hematoma. The TOT, the oblique TOT, produces a hematoma inside the aponeurosis of the gracilis muscle. And the retropubic TOT, as you can remember the presentation of Emmanuel, that not only a single case of gracilis hematoma described. Regarding mini sling, here is the obturator foramen. Here is the obturator artery, and here is the inferior mini sling here. It's very safe, do not perforate, no possibility of growing pain or hematoma. Well, this is a very important concept. Peter addressed it very well, is the how tight to adjust. You have not to indent mini sling, not do different adjustments for any type of sling, because, you know, half millimeters in adjustment may impact on the rotation. So the adjustment should be the same for all patients. You have not to tie too tight, because you're going to have this swan neck signal. You can see here, the bladder neck is up. There is a small cystocele, urethrocoele, a small cystocele. And if you look laterally, this reminds us the bladder neck of a swan. And this is pathognomonic of obstruction. If you find this, you don't need any other additional study to make the diagnosis of bladder outlet obstruction. So the art of adjustment, we adopted now the 8x4, eager dilator 8 in the urethra and 4 between the urethra and the tape. This is a German technique from Cologne. Professor Jager describes this is a very nice way to adjust, and extremely reproducible, because scissors are different. But here we have always the same diameter in the urethra and between the urethra and the tape. Let me show you, this is a very nice study, it came from Bolivia. It's prospective randomized, comparing 8x4 versus scissors. Just so pay attention in the real operation. 0 when you use 8x4 and 11 when you use the scissors, telling us that the 8x4 adjustment is very precise and reliable. When we described the first single incision sling in 1999, we used some biological products and even the SIS, and but we have to dissect the white line, and was not a very easy surgery. So this evolved into new devices, like many that are in the market. And this meta-analysis published in the European Urology, comparing mini slings, single incision with the other slings, excluding TVT secure, because the fixation system is very bad. All the other slings, when you compare, have the same subjective and objective cure rate. This is our 8 years follow-up using the Ophira mini sling, and the cure rate after 8 years is 85%, with 10% improvement in naive patients, 5% only failures. But in patients with the previous failed procedure, we have half of these patients cured after 8 years and 25 improved. And this is not different from other tapes, other approach for previous failed procedure. Well, the comeback of the injectables, I think that's more of the same. We know from years the indications for intraurethral injections, especially in the elderly and unfit patients, the trusal hypocontractility, and we need a well-supported urethra to get some coaptations. And how about stem cells injection? It's not an alternative so far, because there is no innervation nor blood supply to these stem cells. There is not a way to make it grow to the exact amount and to be functionally good. The clinical trials are disappointing. Maybe in the future, maybe a place for tissue engineering, but I don't think that stem cells is not the answer. Another important issue here is lasers. When we hit the vaginal wall, and you see here the urethra is well supported, we can increase the collagen contents and may get some good results. The only study I'd like to show you is from Okui. He presented a prospective randomized clinical trial comparing 50 patients in each arm, TVT, TOT, and lasers. When we pay attention in 1 hour PET test, you see that TVT and TOT improved the same, but the laser was also effective. When we compare the questionnaire ICIQ, SF, it's absolutely the same. But when we compare the urgency questionnaire, OAB, short form, laser performed better than TVT and TOT. The conclusion of this paper, published in the World Journal of Urology last year, is that laser may play an important role in management of mild cases of urinary stress incontinence, although it is still experimental and we do not have long-term follow-up. This is a cadaveric study. You see here the pubourethral ligament, and here the insertion. Here is the pubourethral ligament of this meshless device with the spine and counter spine. That the idea is to do plication of the posterior or retropubic pubourethral ligament. What would be the indications for this procedure? Urethral hypermobility, previous failed slings as a rescue procedure, meshophobia, the unfit patient, because it can be made under local anesthesia in an outpatient basis, and also as an alternative to injectables. So in summary, the prevention of complications includes knowledge of anatomy, surgical technique, tension adjustment, and this is the art of tension adjustment, and surgeon's experience. So, because evolution is forever, primo non nocere, but second, curare. Thank you.
Thank you so much, Paulo, for closing this lecture. Now I don't know, we have some questions. Maybe you, Paulo, could pick them and
yes, my pleasure, my pleasure.
Okay.
The first question from Gabriel Vallejos is for Dr. Petros. Professor Petros, if you perform you put the tape in and do the stress test, but the patient is under anesthesia, how can you think this is a reliable method?
Is it reliable? It's reliable for me because, you see, if you don't have the muscles working, it's like an open drain. And I find that if the tape is too loose before, and I do a cystoscopy and I take the cystoscope out and it's running out, if the urine's running out, it's like a drain. It means that the muscles aren't working. And one of the good things that N. Horning did, N. Horning's thesis is very interesting to read because he showed that even under general anesthesia, the pelvic muscles were actually contracting. So general anesthesia doesn't really knock out the pelvic muscles. The only thing that knocks them out is spinal. If you notice with spinal, they will defecate, but in general anesthesia, they don't. And N. Horning showed that the so there it shows that even under GA or epidural, or light spinal, the muscles are still working, and to me it's reliable. Other than that, you've got nothing.
Okay.
Okay. How reliable? I don't know. I mean, it's reliable for me.
Okay, thank you. Let's move to Emmanuel. Dr. Raquel Lima, Professor Delorme, don't you think that the pain complications are in the majority associated with the in-out technique?
If we look at the publications and the different Cochrane, absolutely not. It's exactly the same for outside or in-outside TOT. Look at the Abdel Fattah publications with the comparisons of the 300 cases in one way and 300 cases in other way. It's exactly the same percentage of complications. But if we look how was the technique, the out in complications, where with no instruction really, where you introduce the needle. And probably the needle was very often not against the bone. The needle must be against the bone and far away is the vascular and nervous structure of the grain. And I think if I compare the result of a retropubic TOT out in with all the series I read in out, yes, absolutely. In these situations, for me and my experience, retropubic TOT out decrease the risk if we compare to in out to have growing pain.
Thank you. Well, we have a lot of questions.
Yes, yes.
I'm sorry we are not in time, but Alejandro, if you allow me for 2 more questions.
Yes, yes, please.
Well, can I make a statement, please? It's
Sure.
very important. Look, we're never going to make progress for new techniques or improving the old if we do not understand how the bladder works, how the continence mechanism works. It's my experience that very few people who do the midurethral sling understand the mechanism of continence. That's all I want to say. That you have to study the anatomy and how the functional anatomy and how it works. Otherwise, every patient's different. There's no such thing as a cookbook, but every patient's different. So you've got to understand the anatomy and how it applies to the individual. Thank you very much. That's what I want to say.
Thanks, Peter. That's a very, very important comment. That's why we discussed a little bit of the theories involved in continence. And of course, if you do know exactly what you are doing, we can have a better result. There is just a question from Russia. If there is concomitant cystocele and incontinence, you do 1 step or 2 steps approach, Peter?
I do it all in one.
About you, Emmanuel? Yeah, I think everybody does the same.
No, I'll tell you why. The important thing is, it's actually a very good question. It's very important when you do cystocele repair not to excise vagina. It's very important to conserve vagina, because if you excise vagina and do a midurethral sling, yes, you can cause a lot of scarring and get problems. But if you can always do a cystocele native tissue without excising it, because all you do is tighten the fascia underneath. It looks bad when you're finished, but within 6 weeks, it looks terrific. So I think the takeaway message is, do not excise vagina. You can do it without excision. And yes, I do both together, always. I've never, ever done them separately.
Thank you. One more question, as I'm allowed to, from Carlos Diaz. Professor Peter Petros, if I understood correctly, you are saying that we must put an extra suture at the end of the urethra in order to reinforce the continence mechanism at the exit of the urethra. Is that correct?
Yes. I showed you there are 2 closure mechanisms. One of the discoveries in 1990 of integral theory was that there were 2 closure mechanisms. The distal closure mechanism, which was closed by the pubococcygeus muscle, pushing the vagina behind the urethra to close it. And the second one was like a kinking mechanism, where it gets pulled back and kinks. And the distal closure mechanism, it takes an extra 2 minutes. It's easy to do. All you have to remember is to improve is to take the incision to within 0.5 centimeter of the meatus so that you can locate the external ligament, and always do it with a catheter inside. Yes, I recommend that routine, whether you do TOT, retropubic, or even mini sling.
Thank you, Peter. I promise that is the last question, Alejandro, but it's a challenging one.
I would love to continue until we answer all of them, but it's impossible.
I know the time is running, but Dr. Jaime Ruiz, thank you for describing your technique, Dr. Delorme. At what level do urethra stays the tape when you do the retropubic TOT? And also, do you also recommend the distal procedure with Vicryl, as said by Dr. Petros?
I can speak what about I have experience. Firstly, I can speak about the level of the tape beyond the urethra. The aim of this technique is to put the tape where the integral theory explains us, between the distal third and the middle third of the urethra. And with retropubic TOT, like that we can do. But in one case, it's difficult. It is when there is no mobility, a fixed urethra beyond the pubic bone. And I think in these situations, it's a bad indication for all kind of TOT technique. Second, about the distal reconstructions of the urethra, the external ligament, I have no enough experience to speak about. And I cannot speak with this small experience about the results, the outcome of this point.
Thank you. Sorry, there's very interesting questions here, believe me. But
okay, let's go with one more, Paulo, and I think we will need to do the
okay.
summary.
Some from Dr. Rogério de Fraga. The question is, Professor Delorme, do you think that retropubic TOT is good for recurrent stress urinary incontinence in case of a previous failure of the classic TOT?
I think it's difficult to answer this question. The first thing is to evaluate where it was a recurrence of incontinence after the first surgery. And it's depends of the pathogenesis of the pathology, the anatomopathology of the bad result of the first surgery. And if it is a good closure pressure, a good mobility of urethra, why not? If it is sphincteric deficiency, it's another problem. And in this case, like in the Cochrane 2017, probably it's better to do retropubic tape if it is with hypermobility and sphincteric deficiency, because we can have 12% better outcomes than with TOT. But if it is really big sphincteric deficiency and patient with a good shape, probably artificial sphincter is the best surgery we can propose to the patient.
Thank you, Manuel. Back to you, Alejandro.
Okay. Well, for me, just to close this webinar, which has been awesome. It's been an honor, as I said, for Promedon, in the name of Promedon, having you, the three of you, behind this space. Emmanuel, we know you were in vacation, so thank you so much for making spot for us. Peter, they are being so late already there in Australia, but still answering the questions. And Paulo, as always, supporting all of these initiatives that we want to bring the science and have the experience available for everyone. So again, thank you so much. And finally, thank you for the Promedon team, Brazilian team, Renata and Andresa, for coming up with this idea. and the headquarters team with Ivan, Cecilia, and Lucia for making this possible. It's been a huge pleasure, okay? And we're looking forward to see you maybe in a couple of months in another session of Meet the Experts or Meet the Legends for everyone, okay? Thank you so much.
Thank you.
Thank you. Bye.
Bye-bye.